for factitious disorder, it's not that something that it's not like disorders that you are going to see quite often, but because it consists of important medical legal aspect. Okay, so that is why you need to learn about it lah. And of course, because it entangles with the presentation of certain medical and surgical illness, kan? When you do practice in other field, sometimes you may come across with this group of patients who presented with psychosomatic symptoms, physical symptoms, all right? But the origin was from psychological. Okay, so without further ado, I will invite our first presenter, siapa? Faris.
Um, apa?
Okay, all right.
Assalamualaikum warahmatullahi wabarakatuh. Okay, so insyaAllah today we'll have a insyaAllah we'll have a tutorial on factitious disorder and malingering. This is our outline for today, which is first I'll explain about factitious disorder and we'll have a case presentation. After that, my colleague will explain about malingering and again we'll present another case. Okay, so for the first topic, which is factitious disorder. Okay. For the definition, it's actually intentional report and misinterpretation of the symptoms or self-infliction of physical signs or symptoms of medical or mental disorder. So in simple terms, it's the falsification of a symptom or sign. And the aim, the reason why the patient does it is to assume the sick role. The patient wants to be hospitalized, and usually there is no secondary gain that the patient can get. It is also known as Munchausen syndrome. Okay. So for the epidemiology, usually affects around 0.8 to 1% of psychiatric consultation, and it usually occurs more in females compared to males. In terms of age group, it affects those who are between 20 to 40 years old, and they are usually unmarried and have a history of employment or education healthcare, meaning like they are either nursing or medical students that have a background in healthcare lah. Okay. And then for the etiology, it can be divided into psychosocial and also biological. So in terms of psychosocial, these patients had a history of child abuse and they have been hospitalized previously, and they found it a way of escape. The hospital is a way that they can actually escape from home, from the abuse environment. And then some patients have a masochistic personality whereby they actually enjoy or they actually seek for the painful procedures, and or they have a history of multiple admission because they want to relieve the fast frightening experiences, and most of the patients have a borderline personality. In terms of biological, they have a brain dysfunction and also have impaired information processing. So they like to make up stories about, they may have some facts in it, but they try to elaborate it in a very dramatic way lah. Okay, so these are some of the clues that can actually we can suspect factitious disorder. So for example, first, as I already mentioned before this, patient usually have a medical profession background, so they actually have some knowledge, so they know what to lie on. And in terms of presentation wise, it's very dramatic and it defies the conventional medical or psychiatric understanding. And they can give it in a very elaborate manner. And even when one symptom resolves, they can have another set of new symptoms after that. And besides that, they can also know when they have treatment, what kind of what will happen after the treatment, whether it will work or not. And they have a lot of drug allergies, and they're very eager to actually undergo multiple procedures and testing. And another thing that can give us a clue is they don't have a lot of visitors, or they are reluctant to actually give information about collateral, for example, contact information about the other family members to actually prove that the history is authentic or not. For the classification, so according to the DSM-5, It's divided into two. First, it can be imposed on oneself, and also it can be imposed on another. Usually, this one is also called mutual by proxy. For example, a mother imposed the sequel onto her child. Okay. And then previously in the DSM-4, they also divided it according to the symptoms, which one is most predominant, either physical, psychological, or mixture of the two. Okay, so this one, first we go to the factitious disorder imposed on self. So again, this is the definition, which is falsification of the symptoms or that induced injury and associated with identified deception. So the patient will actually injure himself and present himself as ill, impaired, or injured. And usually, as I've already mentioned, there is absence of any obvious external rewards, which I think this will go more into malingering after this we'll discuss more. And of course, it cannot be explained by other medical or mental disorders. For example, a delusional disorder or other psychotic disorder. And we can specify further based on how many episodes the patient has, whether it's single or recurrence. Okay. For the imposed on another, Jensen by proxy, it's the same definition but just difference in terms of who they do it on. So it's on another person, on an individual, which is also known as the victim. So in this case, the mother may assume the child or the aging family or somebody to assume the sick role. Okay. These are just a few questions that we can ask ourselves if we suspect a patient to have Munchausen syndrome by proxy. So is the history of the mother consistent with what the child is presenting, and is there any diagnostic evidence to support the history, and did any of the other staff also witness what happened, and sometimes a negative test doesn't actually reassure the mother. She feels scared that she might be found out that she's actually lying. And also in terms of treatment, is the patient getting treatment because the mother insists on it? Is based on the demand. Okay. Okay, so the others, this one is according to which symptom is more predominant, whether it's physical. Okay, so this one is the type that is common in medical personnel, whereby they can give a factitious history, for example, saying that they had a seizure, or putting, like for example, putting blood into a sample of urine sample, which is that they actually contaminate the urine sample on purpose. Or sometimes they can actually take psychoactive drugs because they want to induce psychiatric symptoms. So these kind of individuals are prone to seek different hospitals. They go from different hospitals to actually falsify their symptoms. Okay, and just some examples to give you an idea. Like for example, patient who they can actually use makeup or cosmetics to actually draw the malar rash in SLE and pretend that they have joint pain, and also they can purposely inject insulin to say that they have hypoglycemia. And another example, if they want to pretend they have had chemo, they may have shaved their head, so on and so forth. Okay, and then this one is for predominantly psychological symptoms. So this one is more chronic in terms they pretend that they have a psychological symptom. For example, they have low mood and all the features of depression or psychotic symptoms, any of these symptoms are. And what can point to that is that they have had several medications, and all of it is it doesn't work on the patient. The patient is on multiple drugs. At the same time, even ECT doesn't give any improvement to the patient. Okay. And also these kind of patients, usually in the end, they are found to actually have a diagnosis of borderline personality disorder because of the impulsivity of their actions and all that. Okay, and this one is whereby there is a combination of both psychological and also physical signs and symptoms. In terms of investigation, there's nothing really for diagnosis. It's more to rule out, to show that there are some symptoms just deceiving, and also to rule out any drugs that they may be consuming to actually say that they have these signs and symptoms. Okay. And then for treatment, there's no specific treatment for it. It's best to focus on the management rather than cure. And the most important thing is actually to recognize it early lah, to avoid macam putting the patient under unnecessary investigations and all that. And from the books, it says that there is no psychotherapy, that there's no consensus on what type of psychotherapy is best for these patients. But for pharmacology, SSRI can be given, especially those who have impulsive behavior. But the most important thing to think about is to make sure the patient does not abuse the medication. Okay, so I think that's all for my part. I pass to my colleague Hidayah. Dengar. Hmm. Doctor, we cannot hear you.
Sorry doctor,
Doctor,
your mic is mute.
Oh,
your
okay,
mic
sorry.
tak.
So, okay, I have a question to Afa. How do you confirm the case where the mother inflicting the injury to the child? As an example, when you see the patient in pediatric ward and you suspected a factitious disorder imposed on other kan, Munchausen by proxy. How do you confirm basically? How can
First we can ask
while the
history
mother
from
is
the
in the
mother.
ward? Uh,
Apa dia?
how can you confirm that it is basically induced by the mother?
So first we can actually ask the mother herself about history, what happened, and
Mm-mm.
then depends if the child is old enough. Maybe we can get some history from the child as well, if the child is willing to share. At the same
Mm-mm.
time, we can, for example, if the mother has uh, said that the child has multiple emission previously, we can call and check trace the old notes to confirm whether the history that's given is consistent with the previous history, previous admissions, if patient has multiple admissions, and also collateral history from the other family members. Maybe the father, if you also witness what happened. Yeah.
Sometimes the simple approach you can do is just by removing the mother
Child.
from the child. Yes, sometimes
Mm,
we purposely let the mother not to be around the child. So
mm,
and you will see that the child no longer apa ni presented with the whatever symptom that the mother is claiming lah kan. So
mm,
sometimes that is quite a
mm,
common acceptable approach you can do if the occurrence was while the patient is in the ward lah kan.
mm.
Okay, okay, maybe we can have a look at the case scenario.
Okay.
Alright.
Yeah.
Can you present my slide? Sorry for that. I don't have any problem.
That's right. Can you guys see it?
Not yet, Fah.
Yeah.
Sekejap.
Nampak kayak gitu. Can you stop sharing and buat kayak gitu? Stop sharing.
Dah yang slide yang lepas
Sekejap. Saya cuba share lah. Sekejap. Boleh tak? Okay. Uh, Now I'm trying to present my slide. Can you see it?
Afaf stop.
Boleh?
Nampak yang Afaf present tapi tak nampak yang Hidayah present.
Oh, ya ke? Okay. I stop my sharing. Apa ada share ke?
Hidayah, I think you can present now. Sorry. Afaf punya laptop pun masalah. Okay, we can see it.
Okay. Right. Okay, sorry for the technical delay. Can you see my slide, right? So, I am Hidayah. I will continue the presentation with some example of factitious cases where they were reported in online journal. So, let's go with the first case. BC, a 1-month-old girl, was admitted for the evaluation of fever. Her mother, Madam M, has gave inconsistent medical information regarding her child, despite her presentation as a knowledgeable mother who worked as an emergency medical technician. Due to the condition, psychiatrist consultation was requested. Okay. Further exploration, Madam N reported her own diagnosis of ovarian cancer when she was 3 months pregnant with BC. She told the doctor she had undergone a hysterectomy during her cesarean section, and since then she was on radiation therapy at a local hospital since BC birth. So doctor want to confirm the history. So doctor asked mother's permission and called the local hospital, and the doctor learned that the mother already had a corpus luteum cyst during pregnancy and already removed at 3 months gestation with finding of mild hydronephrosis. But there's no history of cancer, there's no history of hysterectomy. Okay. So doctor confront the mother, and the mother said only that she might need a kidney transplant for the hydronephrosis. On further exploration, the mother had history brought her son to clinician and tell the clinician that her son had lupus and hypergammaglobulinemia. And at another visit, she said that her son had asthma and seizures. So the doctor suspect that Madam M intentionally fabricated symptoms of her son, such as by warming BC's thermometer, and she did not actively induce symptoms in her child. The mother denied the action, and she also denied any psychiatric history, but she gave permission to contact the psychiatric hospital. And from the communication, the doctor know that the mother already had history of depression, anorexia, panic disorder, and a suicide attempt resulting in a psychiatric admission. And the mother also had received psychotherapy and pharmacotherapy, which stopped a few months prior to this presentation. So during BC admission for fever, her mother agreed to resume psychiatric treatment, and she was referred to social service, and the pediatrician decided to regular follow up her son. Okay. From this case, when we go through this story, we know that this is case of factitious disorder by proxy or factitious disorder imposed on another. Yeah, in this case, her mother present her child as ill or sick, and her mother creates or exaggerate the symptoms regarding her child in order to obtain attention received through child symptom. Okay. And another case is a 39-year-old single and unemployed male presented with traumatic severe abdominal pain. He was vague and inconsistent when doctor asked regarding the nature of the pain. And after all the investigation proved negative, he started to complain of chest pain. And the doctor suspect that this patient was intentionally produced the physical symptom, and he was referred for psychiatric assessment. Further exploration revealed that his past medical history show that he had been admitted to different general hospital, and she had repeated medical and surgical consultation, including extensive investigation. However, the result was he has no any physical illness or any physical disorder. From psychiatric assessment also, there's no evidence of mental disorder. During his stay in the psychiatric admission, he presented with acute renal pain, hematuria, and evidence of self-induced blood thin stool. And the doctor confronted the patient about the complaint after organic causes had been ruled out. He started to become angry, and he wanted to discharge at own risk. But then the story does not end here. 2 months later, he continued to appear in the same hospital with different symptoms. He pretend to have symptom of acute asthma, and sometimes acute chest pain, and doctor managed him by confronting his symptom, but remaining supportive. Okay. So other differential diagnosis that we might consider when patient present with factitious disorder, one is malingering. So patient with malingering disorder, usually they have obvious goal in producing sign and symptom. They want to get MC so that they will avoid going for work. And second is we can rule out either patient has somatic symptom disorder, in which a patient present with somatic symptoms that cause significantly distress in patient life. And usually symptoms are accompanied by excessive thought, feeling, or behavior related to somatic complaint. Um, for example, um, patient has headache, and they interpret headache as they have brain tumor. So the idea of having brain tumor keep persisting despite repeated reassurance and negative physical examination. Okay. Next, differential diagnosis we can consider is conversion disorder, in which patient present with sudden involuntary loss of motor or sensory function, and the symptoms usually mimic the medical problem, but there's no underlying medical condition could be explained. And usually the symptoms occur following the physiological stress. For example, the police officer present with hand weakness or hand paralysis following the experience of shooting or killing a person. Okay. Next diagnosis is next differential diagnosis is borderline personality, we should consider in patient present with factitious disorder because patient may have uh, uh, chaotic lifestyles and disturbed interpersonal relationship, identity crisis, and also self-damaging acts. And last one is schizophrenia because patient may also present with bizarre delusion. Okay, so that's all for me.
Okay, ada soalan tak? I hope you are clear with the case illustration. Few examples to illustrate the factitious. Of course, it's not common cases that you get to see, but because of the importance to detect it and the medical legal aspect of it, so then you have to learn about the disorder lah. Okay. If no question, then we move on to the next presenter.
Doctor,
Yeah.
I have a question.
Majiha.
Sorry because a camera. Apa? In case of chosen by proxy, does it consider as abuse also if the mother somehow inflicted pain on the child?
Yes, obviously, it's a form of child abuse lah. Normally, the mother or the perpetrator is having some kind of underlying personality disorder as well, kan? Especially cluster B. So that's why that is how they they manifest the presentation. So it's considered as a form of abuse. So that's why the care of the children shall be managed with the presence of social worker, kan? Or some the social worker need to identify lah whether the mother is fit or not fit to actually manage the child lah. If then the child will be put under other family members lah, the custody, until the mother got her treatment. Alright, next one is malingering.
Okay, Bismillahirrahmanirrahim. So I would like to continue with the topics of malingering. Okay. Right. So by definition, malingering is a deliberate falsification of a physical or psychological in an attempt to achieve a secondary gain. So the differences between malingering and factitious disorder is that malingering they have the aim to achieve a secondary gain, while factitious disorder they want to have a stick role. So it's considered as a primary gain. So among the reasons of the secondary gain are, number one, they want to avoid military duty, avoiding any work ataupun obtaining financial compensation, ataupun to evade criminal prosecutions or obtaining drugs. Right, now moving on to the next slide. There is a few fundamental difference that differentiate between malingering and factitious disorder, in which it is based on the intentions of the patient. As I said before, in malingering, the motivation is external. They want to get the money, they want to evade from doing any works. But in factitious disorder, the motivation is internal, meaning that they want to get the sympathy from other persons. They want to get the sick, want to be hospitalized without any significant reasons. And the point to differentiate between the two is that malingering is not considered to be a mental illness, whereas factitious disorder is considered mental illness. Now, epidemiologically, it is common among hospitalized patients to be malingered. So it is significant in men rather than women and affect 1% of civilian mental health practice, 5% in military. In criminal defendants, it's about 10 to 20%, meaning that if they want to be charged or prosecuted, so they malinger and say that they are sick so that they can be evaded from the prosecution. So 50% of children with conduct disorders also have a serious lying related issues with regard to their health. Okay, now the etiology can be attributed to the personality. So frequentation seen between malingering and antisocial personality disorder. that raises the possibility that hypoarousability may be an underlying metabolic factor. However, there is no genetic causes or neurophysiological, neurochemical causes that are presently known to cause uh, the malingering activity lah. Okay, so based on DSM-5, malingering should be suspected if number one, it is medical legal context of presentation. For example, the patient is referred by an attorney um, to have their health to be checked. So this is one of the indicator. Number two, there is a marked discrepancy between the individual's claimed stress or disability and the objective finding and observation. So they say that they are excessively sick tapi kita tengok tak nampak macam sakit pun lah gitu lah. And then there is lack of cooperation during the diagnostic evaluation and to comply with the prescribed treatment regimen, and the presence lastly is the presence of antisocial personality behavior. Okay, now the presentations of the patient, normally they will be presented with vague complaints that do not inline to a non-medical condition. Okay, they have a long medical history with many hospital stays before they come to us, and normally they are uncooperative and refuse to accept a good prognosis. A normal patient would be happy if they got a good prognosis, but they seems to be unhappy and uncooperative when they got the good prognosis. Right, and their symptoms normally improve once they get the desired objective. Okay. So the diagnosis and clinical features, as I said before, they avoid criminal responsibility, trial and punishment. They want to avoid a military service. They want to get a financial. They want to get financial compensation, avoid work or social responsibility, facilitate a transfer from prison to hospital. Meaning to say, if a prisoner, they can malignate about their health because they want to be transferred from prison to hospital for whatever reason. And then lastly, they have a drug seeking behavior. Okay. Now, there is a few differential diagnoses that we can think of when we talk about malingering. So number one, factitious disorder. So we need to know whether the patient, what is the intention of the patient to be lying about their health. So if it's primary emotional gain, if they want to get a sympathy, so it's probably this is. But if their aims is to get an external gain for compensation or etc., so this could be a malingering. Not to forget that there is a one psychiatric problem known as conversion disorder. So conversion disorder actually is a psychotic condition in which there is a sudden loss ataupun involuntary loss of motor and sensory function that mimics the medical and neurological symptoms. So this is normally temporal with the psychological problem. For example, patient had a stressor, patient got divorced. So after sometimes patient develop paralysis grade 0 that cannot be explained by any spinal pathology. So this can be caused by a conversion disorder. So as you see, conversion disorder is involuntary symptoms. Patient did not aim to get that illness, and normally they are cooperative, they are friendly, and they welcome the evaluations and treatment because they want to be healthy, and they accept employment opportunity if the disease persists. Okay. So the last point is they report historical gaps and inaccuracies, where malingering, they have extremely detailed and exacting events relating to illness, meaning that they have been researching about the illness that they want to malingate about, and then once they convinced enough that they know about the disease, then they only tell the physicians or the doctors what the they have, what the illnesses that they have. They can tell us in extremely detail because of their reading compared to conversion disorder. Okay, next. Okay, so regarding the cause and prognosis, so as long as the patient did not get what they want to get, they will continue to be malingering. So it persists as long as the malingerer believes that they may benefit. Okay, and once they get what they want, the symptoms disappear. Right. So in children, malingering is most likely associated with predisposing anxiety or conduct disorder lah. Okay, then the treatment first, before you treat, you need to have a careful differential investigation. You need to exclude the somatic symptoms. You need to exclude if there is true medical illnesses in the patient before you say that this is malingering. Alright, so the patient should be tactfully but firmly confronted with the apparent outcome. So you need to confront the patient with regard to the symptoms that they are facing about, and you need to know what is the reasons, what are their external aim ataupun external gain that they want to get. And you need to know also if they, what is their plan if they don't get it, what is their alternative pathways to get the aim that they want. And then next is coexisting psychiatric disorders should be thoroughly assessed as well. Okay, I think that's all. Okay, next. So I think that's all for my inquiry.
Okay, so I will continue with the case scenario for malingering case. Okay, so okay, so this is a 23-year-old man with a history of blunt trauma to his right hand. So what happened was, while working, an electric motor rolled on his right hand and forearm, resulting in swelling and abrasion on the dorsum of his hand and elbow. So this occurred while he was working. So, however, when during investigations, there were no fractures seen on the radiographs, and therefore no surgery or sutures were needed. However, he still complained of constant severe pain. So, due to this, he was diagnosed with complex regional pain syndrome, without objective imaging confirmation. So, just a side note, CRPS is usually is actually a chronic neuropathic pain that follows an injury to either to soft tissue, bone, or nerve, and it's usually a clinical diagnosis whereby the pain is out of proportion of the injury itself. So he was diagnosed with CRPS, and the management was symptomatic management with pain relieving medication lah. So after failed oral medication, so at 3 months after the injury, he was given a cervical epidural block. At 4 months after the injury, he was given stellate ganglion block. At 5 months, there was intravenous block. Basically, all of these medications given did not improve the pain at all. So at 7 months after the injury, he was dorsal column stimulator was implanted, in which he claimed relief only 50% of the pain. Okay, so 15 months later, after the injury, the patient finally presented for a medical evaluation. So this is a medical legal case because as part of the workers' compensation litigation process, because he wants to claim for the workers' compensation lah. So during this presentation, he still claimed of constant pain, and he was unable to use his right hand and with a limited range of movement. So upon physical examination, so this is how the patient presented. The patient held his right hand in a clenched fist. In a clenched fist posture with his fingers overlapping. So he held his elbow and wrist in a flexed posture and adducted against his body. So he would only abduct his arm minimally at the shoulder because he claims that it would cause pain. Okay. So it was also noted suspiciously that the patient was suntanned, including the axilla area on the right side, which should be impossible if the patient could not raise his arm, right? And also on his right chest. And it was noted that all his fingernails was chewed short on both hands. So on questioning, he stated that he did not bite his nails on the right hand because he could not get his hand to the mouth. And he claimed that he picked the nails of his right hand off with his left hand. So he later stated that his right hand was too tender to be touched. However, on examination, there was no allodynia. And surprisingly, there was also no obvious atrophy upon examination of the upper extremities, even though he claimed that he have not been using his right hands for already 15 months, which is a year and more. So there was no obvious atrophy. So upon further questioning, the patient claimed that his right hand and had been in that position, fixed position, for 6 months. However, upon gaining history from his wife, he said that he had held his hand in that position for 1 year, which was a discrepancy lah. And his wife stated that his hand did open while sleeping. So on further investigation, they did a bone scan, and mineralization of the bones was symmetrical on bilateral radiographs. which is inconsistent with the history if he claimed that he hasn't been using his right hand for the past 1 year. Okay, so a private investigator was hired by the patient's former employer. So this showed that the video surveillance showed that the patient was using his right hand. He was grasping and casting repeatedly with the fishing rod. That he claimed to be non-functional with the full range of motion. So basically, he was able to use his right hand perfectly and normally. So, so from this case, we know that the patient initially had a true injury. So, and then he was diagnosed with CRPS. So, in our clinical setting, the patient may actually have a true history, and may be diagnosed with a true diagnosis. But later, after several investigation and even after treatment, whereby if the patient does not respond to treatment, we may change our diagnosis. So in this case, the diagnosis of malingering was objective when the patient is observed to have the ability to perform the activity which he previously denied. And then there was also a lack of disuse atrophy, and he had symmetrical imaging studies, and there is a secondary gain, which is the workers' compensation. So I think that is all for the case. Thank you.
Okay, thank you. Any question to the presenters regarding malingering? Pernah jumpa ke you all ni? Nanti because when you will be doing the housemanship, you'll be the first person kan in the ward. So normally those suspicious patient yang ada banyak repeated admission kan, yang inconclusive on the investigation findings. So sometimes these are the things that you should watch out for lah, and especially if there happens to be an obvious secondary gain kan. And then among the occupation, you tengok kan, army personnel, police officer, and then because try to have a look about the secondary gain that the patient may get upon their admission, hospitalization kan. Sebab you need to be cautious lah sebab medical legal aspect tadi. Sometimes dia tak nak kena denda dekat camp, dia tak nak pergi court, dia ada trial, dia tak nak avoid responsibility lah. So nak compensation like the example just now. So those are the secondary gain, which is different from the factitious just now when the patient sole intention is for the primary gain, kan? So kena tahu the difference lah, alright? Okay, ada soalan tak? Clear So of course, the occurrence are more common among patients who had some form of personality disorder, kan? Especially the cluster B, okay? Borderline, histrionic, antisocial personality. So they tend to be more commonly presented with these disorders we are discussing today. Malingering, factitious, okay? Alright, kalau tak ada soalan, then we move on to our next slot lah. You all nak 5-minute break dulu. 5-minute break.
Yes.
Okay lah. So 5-minute break and then we'll start with our seminar. Boleh? Okay, good.
Boleh ada.
So 3 suku kita jumpa Okay.